Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS Webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Suichi Oya. Professor Oya is a professor and chairman of the Department of Neurosurgery at the Gunma University Graduate School of Medicine, Japan. Prof. Oya is a prominent member of the Japanese Neurosurgical Society and earns his expertise in skull base and vascular neurosurgery and has published several articles in this field. He was a skull base surgery fellow at the Cleveland Clinic Foundation Brain Tumor and Neuro-Oncology Center, USA. His research interests are focused upon brain tumors, skull base surgery for tumors and vascular lesions, carotid atherosclerosis, aneurysms, and cerebrovascular reconstruction. He is an invited faculty to several workshops and conferences all over the world. He is also a noted author with several publications in leading peer-reviewed journals. We are extremely honored to have him today at our webinars, and today he will be talking about clinical research originating from trivial findings gained in everyday clinical practice. The speaker for the second session of today is our honored guest from China, Dr. Nidan Qiao. Prof. Qiao is an associate professor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai. He was a previous research fellow at the Neuroendocrine Center, Massachusetts General Hospital. He is a noted author with over 70 publications in journals and also author of the book Deep Learning in Medical Big Data. We are extremely honored to have him today at our webinars, and today we will be talking about intelligent diagnosis and treatment in patients with cellular tumors. The chair for the first session of today's webinar is our honorable guest from Saudi Arabia, Professor Imad Kannan. Prof. Kannan is a chairman emeritus in the Department of Neurosciences, professor and senior consultant neurosurgeon, director of KSFH and Research Center and WFNS Skull Base International Fellowship, King Faisal Specialist Hospital Research Center, Riyadh. He was the president-elect of the World Academy of Neurosciences and founder and honorary president of the International Neuroanatomy Association. He was the chairman of the WFNS Covili Award Committee and the past president of the AOICSBS and ACNS. We are extremely grateful to him for accepting our invitation and chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Canada, Professor Pierre-Olivier Champagne. Prof. Champagne is a professor in the Department of Neurosurgery at the Laval University, Quebec, Canada. He is a skull-based neurosurgeon who specializes in minimally invasive skull-based surgery by application of endoscopes. He was a former fellow at the Pittsburgh University, USA, and is in charge of the Laval University Cadaveric Laboratory, where he organizes yearly Laval skull-based course. He is a renowned author who has published several articles in various peer-reviewed journals. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. And with that introduction, I'd like to hand over this online podium to our first chair, Prof. Imad Kannan.
Thank you, Professor Vaja. It's my distinct pleasure and honor to introduce the first speaker, Professor Suichi Oya. And I know him for many years. He's an stout skull-based surgeon and vascular surgeon. He has contributed tremendously to this world of skull-based and research and the clinical aspects. I found the title you have chosen, Professor Suichi, very interesting. It's not the orthodox title, as would be the clinical research originated from small and trivial findings gained in everyday clinical practice. A very exciting address, and I'm looking forward to hear this. And I welcome all the audience worldwide and the podium on this webinar. Please, Professor Suichi.
Thank you very much, Professor Imad Kannan, one of my best friends in the world. And it's my great pleasure to be able to join in this wonderful webinar. So let me start my lecture. You know, as Imad says, there's this title, or my title is sounds something strange, but I hope you enjoy it. Well, I always want to teach young doctors I'm working with about the art and science of neurosurgery. This is just how I was raised by my mentors. That may make me sound like a highly skilled neurosurgeon, but that's not true. There are many respectful neuroscientists in the world. As we all know, neurosurgery is certainly a busy work in place. There was a time when I spent almost all my life in the hospital ward to care for patients. There was a time when I spent, excuse me, okay. Yeah, literally, I was a resident. However, even so, I find it fascinating to address the questions that arise in my daily clinical work. It may seem trivial, such as refining surgical techniques and diligently managing patients before and after surgery. My talk today will not be very serious, so please sit back and feel free to listen. I think everyone has a few mentors. Mentors are extremely important. In my case, Professor Fujimaki was the first person who taught me many things. When I started my training at the University of Tokyo Hospital, I immediately encountered this patient. This patient was the same age as me and had undergone surgery for ependymoma at the age of 2. The brain images from that time were still available at the University of Tokyo. Although the tumor had been completely removed, it recurred when the patient was 25 years old. Professor Fujimaki told me this case doesn't follow Curran's law. It's interesting, so write a case report. At the time, I was more obedient than I am now, so I immediately started the work. It was a time when gathering articles was quite time-consuming. It was my first time doing such work, but I gave it my all and completed the case report. I submitted it to numerous journals, but all of them rejected my first lovely article. Finally, it was published in the Italian journal called Tumor. Though small, it became a valuable success experience for me. So this is the paper published in Tumor. There are various clinical studies. Multi-center RCTs generate high-level evidence, but these are not included in my presentation today. I'd like to introduce some researches I was involved to emphasize that even residents who are working very hard every day at the bedside can do small but important researches. I was born in Fukushima Prefecture, which unfortunately became famous due to the big East Japan earthquake. This is my hometown. It's a beautiful mountain village in both summers and winters. Aizu Hospital, where I underwent training after graduating from University of Tokyo, is located here. Although it was not a large hospital in the countryside, it was a very good hospital where everyone worked very hard. The late Dr. Kazuo Tsutsumi was one of my mentors. I was very fortunate to be able to receive education from Dr. Tsutsumi at this Aizu Hospital. Dr. Tsutsumi was a master surgeon, but he also valued scientific thinking, publishing original articles in journals such as Stroke and JNS from this small countryside hospital. He was also known very well for his rigorous surgical training. There was no word in his dictionary like on-call shifts or team systems. Even in the middle of the night, all young surgeons were required to join or observe emergency surgery like aneurysm clipping. However, he allowed the young doctors to perform the surgeries as much as possible. And he himself would always come to the hospital to teach us even during the midnight. At the same time, he would scold us very harshly if we did not do our best for patients after surgery. These are the notes which I compiled during the time for my surgical studies under his supervision. This is a kind of treasure for me. Dr. Tsutsumi encouraged us young surgeons to write case reports whenever we encountered cases showing even slightly interesting causes. So I often wrote small case reports like this. Looking back, these case reports were really trivial and had little clinical impact. However, at the time, I could not understand enough about neurosurgery to know what is interesting or what is not interesting. So I just wrote case reports whenever Dr. Tsutsumi told me to do so. I then imitated what Dr. Tsutsumi did and submitted them to stroke, JNS, and neurosurgery, and so on. Of course, the consequence was miserable, as you expect. They were completely ignored, and I received a barrage of rejection letters. These case reports were gradually pushed down the pipeline and eventually ended up being published in the Japanese Journal of Neurosurgery. This experience was really painful, even for someone insensitive like me. But one day, I took charge of another emergency patient. It was a case of pituitary apoplexy due to pituitary adenoma, now called PITNAT, which resulted in lethargy due to hyponatremia. Their serum sodium level at admission was 106 mg per liter. I carefully began the correction of hyponatremia. However, while I was on night duty, the ICU nurse called me and reported that the patient became unconscious. Upon examination, the patient was comatose with the mouth half open and the saliva flowing from the mouth, and the deep tendon reflexes in the limb were hyperactive, consistent with spastic paralysis. The sodium level had unexpectedly risen to 132 mg per liter in the past 48 hours. Even a young, stupid doctor like I could understand what is happening. This is bad. This is the onset of central pontine myelinolysis. At the time, either Qiao hospital, a hospital in a rural area, had only one PC connected to the internet. So I searched PubMed and found a report on the therapeutic effects of rapidly lowering sodium levels in rat experiments. So where I started administration of the desmopressin and the distilled water in the following 2 days. And let me tell you, now I'm smart enough to say we are not allowed to do such experimental therapy based on a rat study. However, he showed a dramatic recovery. So this time we wrote a case report and submitted it to Neurology, a very famous journal. We had a completely different reaction from the cold responses we kept receiving before. The editorial office of Neurology sent a fax to a hospital in rural Japan saying, correct English in this section, add this data, and let us know when it will be ready. I was very happy to learn that if a case report is truly interesting, the editorial office of even a renowned journal will approach you. This report has been cited in a well-known textbook on nephrology, meaning that even a single case report can have a significant impact. So if your boss tells you to write a case report, just do it. By doing so, you will learn how to write case reports. The first one is the most challenging and time-consuming, but the more you write, the easier it becomes. Since it's the case you yourself have experienced, you will find it interesting. And it's also a responsibility towards the patients you are responsible for. Moreover, even a small case report is an entrance into science. This is one of the advantages of being a clinician, which basic researchers do not have. In terms of fulfilling my responsibilities towards the patients, I also had this experience. A young lady presented with prolonged appetite loss over the last 6 months. Repeated gastroscopies or colonoscopies did not detect any abnormal findings. She had to quit her job, and she started sleeping all day long. Her parents were so concerned and took her to a mental clinic where she was diagnosed as anorexia nervosa. She started taking medication. However, one morning, she suddenly collapsed at home. She was taken to my hospital in a condition of CPA. We could resuscitate her, and the head CT scan was like this. A neurosurgeon would immediately recognize what happened. It was hydrocephalus caused by a cystic posterior fossa tumor. We rushed her to the OR and did an emergency craniotomy and a tumor resection. During surgery, we came to know it was a hemangioblastoma with a very, very small mural nodule. Despite these efforts, she passed away. If only she had been diagnosed sooner, she must have survived. Why were these symptoms overlooked? There was another similar case at my hospital at the time. Upon reviewing the literature, I found 7 reported cases of posterior fossa tumors presenting with emaciation and diagnosed as anorexia nervosa. Among these, 4 cases were hemangioblastomas, which I felt was disproportionately high. So I hypothesized like this. This might be because cystic hemangioblastomas tend to enlarge near the brainstem, but they are less likely to present with focal neurological deficits like meningiomas or schwannomas. Instead, they usually show non-focal symptoms such as headache or appetite loss with a gradual progression, but this may be a misunderstanding. I interpreted this as a focal deficit in the nucleus tractus solitarius, which is the center of appetite regulation. I wrote a case report emphasizing the importance of brain screening for appetite loss. The report was submitted to neurology and accepted. This paper was written for internal medicine doctors and psychiatrists rather than neurosurgeons. For that reason, I believe neurology was the most appropriate journal. Case reports can sometimes lead to the discovery of important new functions of the brain. This 44-year-old woman presented with depression and flat affect for 1 month, along with decreased energy. Medical examinations ruled out medical conditions such as hypothyroidism. However, an MRI for the screening identified a small contrast-enhanced region in the cerebellar column. Additionally, SPECT revealed reduced blood flow in the left frontal lobe, and also the MRI showed the edema around this region. Various depression and anxiety batteries indicated a state of moderate depression and anxiety. The CSF protein level was slightly elevated. Some sort of demyelinating disorders were suspected, so we asked our neurologist to try steroid pulse therapy as a diagnostic treatment, which showed no improvement. So with the patient's consent, we removed this small cerebellar tumor. The pathological diagnosis was hemangioblastoma. Her postoperative course was unbelievable. Her depression and flat affect disappeared completely within 1 week. Depression, anxiety batteries also returned to normal. Edema was resolved, and blood flow in the left frontal lobe increased. While motor control has long been considered as cerebellar function, recent findings have revealed its involvement in cognitive functions and affection, leading to the emergent awareness of CCAS, Cerebellar Cognitive Affective Syndrome. We were sure that this was a very interesting case, so we submitted the case report to neurology. Immediately, our sub-editor specializing in this paper was assigned. She was so energetic to ask us to revise it as many as 5 times until the content was satisfactory. So this process was truly educational, and I felt the dignity and the pride of renowned journals that strive to pursue higher quality, even in case reports. My young colleague, Dr. Inoue, tried her best on this case report, but since we were both busy during the daytime, we responded to revision requests from the sub-editor starting from 5 a.m. Then one morning, we finally received the acceptance letter. I hope this experience was also priceless for Dr. Inoue as well. Of course, we did not discover this phenomenon, but we believe that this case report has important insights into the function of the cerebellum. We were also able to demonstrate that even ordinary surgeons can contribute to this field. It was our great pleasure to have Dr. Sumarman, our world leader in this field, wrote an editorial. The next step is to apply what you have learned from writing case reports to write original articles. Of course, it's a rocky road to become a skillful neurosurgeon. However, even busy neurosurgeons who strive daily to improve their surgical skills can engage in seemingly small but meaningful studies. To do this, you should adopt a mindset that seeks to resolve questions in daily clinical practice. This is because daily clinical practice is filled with unrecognized clues. These mindsets include carefully checking every detail of the routine imaging findings, or listening closely to patients' voices during routine rounds at the bedside. I'm going to show you 2 examples from now. Okay. Well, the first one is I see a blood-blister rupture aneurysm. Even with the advancement of endovascular therapy in modern era, in my opinion, I believe there is no doubt that high flow bypass and proximal or ICA trapping are safer treatment option for this type of aneurysm. So if you have a good handover anastomosis, you can make a EC-RA M2 bypass within 30 minutes, and after you can secure the distal flow. In the intraoperative ICGVA show the good patency of the bypass, and then while if you have the breathing from the aneurysm while your observation, you already secured the cervical ICA and the distal vascular flow, so you don't have to rush. Just put the grip to the distal portion of the aneurysm and put another grip to the proximal portion to the aneurysm to trap it. And this is the PCOM. And all you have to do is just to ligate the ICA. So the aneurysm was gone and the patient had a good outcome. But how about this? The aneurysm is located at the anterior wall of the left ICA. But is this a blood-bridge aneurysm or a true sacral aneurysm? Since there is no way to determine which is the case, if it's a blood-bridge aneurysm and if bleeding occurs during surgery, we may have to sacrifice the ICA. Therefore, we decided to perform high-flow bypass first and then observe the aneurysm. So in this case, we made the high-flow bypass first. And while I'm checking the condition of an aneurysm, I noticed that this aneurysm was a true aneurysm, not the pseudo, dissection. So I could apply the ordinarily slightly curved clip to the healthy wall of the aneurysm neck. So in this case, we didn't have to do high flow bypass. The patient recovered very well, but in Hindo site, this bypass was not necessary. So I've always been thinking that it would be easier if we knew the characteristics of the aneurysm wall in advance. I mean, if we know it's just a true aneurysm before surgery, I can skip high flow bypass. But this is Dr. Indo, my young colleague. He's different. He was a doctor who always looks at the angiograms very carefully. One day he told me that he noticed that the origin of the ophthalmic artery is frequently anomalous in cases of ICA anterior wall aneurysm. So we decided to analyze the origin of the ophthalmic artery to predict the characteristics of the aneurysm wall before surgery. By reviewing 1,643 internal carotid artery angiograms, we found 16 cases, which was 0.967% of an ICA anterior wall aneurysm. Next, we classified the origin of the ophthalmic artery into 4 categories. These were from C2, which is normal, from C3, from C4, and from ACA, with frequencies of 98.1%, 1.6%, 0.2%, and 0.1% respectively. In cases of ICA with an abnormal origin of the ophthalmic artery, the risk of developing an ICA anterior wall aneurysm was surprisingly high, 50 times higher. However, the primary objective of this study was to determine whether we can predict the characteristic of the aneurysm wall remained to be clarified. This remained to be clarified due to the limited number of cases. However, no aneurysms with the firm walls were identified in cases with normal origin. So a significant difference might emerge with a larger sample size. I'm not going into the detail today, but we speculate our observation is related to the embryology of the ophthalmic artery. The content of this study was published in Journal of Neurosurgery. Let me introduce another recent study based on the bedside perspective of a surgeon. The primary goal of revascularization for carotid artery stenosis is secondary prevention of stroke. Carotid endarterectomy and carotid artery stenting have demonstrated nearly equivalent treatment outcomes in recent clinical trials. Therefore, the treatment modality is currently determined based on the patient comorbidities, characteristics of plaque, and their anatomical risk factors. Then what about other potential effects of carotid artery stenosis treatment beyond stroke prevention? Among these potential benefits, the most notable topic has been the improvement of neurocognitive function. However, despite numerous studies, the efficacy of improving higher brain functions has not been established. The reasons for this include variability of preoperative cognitive dysfunction among patients, varying time intervals between stroke onset and treatment, inadequate assessment of the dominant hemisphere, difficulty accounting for individual differences in the development of the circle of Willis, and the challenge of quantitatively demonstrating the association between postoperative cerebral blood flow and improvements in neurocognitive function. Recently, improvements in depressive symptoms have been reported, but the diagnosis of carotid artery stenosis itself may be a cause of preoperative depression, And the post-operative improvements may simply reflect the natural recovery from the natural recovery following treatment. Here again, we have pay attention to the patient's real voice. Not a few patients are telling us, I can see things better after surgery. I believe that assessing visual recovery has several advantages. The eye has a relatively simple anatomical structure, receiving blood flow almost exclusively from the ophthalmic artery. And the quantitative functional evaluation, which is vision, is possible. Additionally, the ophthalmic artery is believed to lack the autoregulation found in cerebral arteries. And it's not influenced by individual variations in the circle of Willis. Lastly, compared to the brain, the retina would require significantly less time to convert optimized oxygen and glucose supply into functional improvement. So the first study aimed to investigate improvements in visual acuity after CEA. We used laser spectrography to measure the blood flow velocity of the retina. First, a preliminary experiment was conducted to determine the sample size. The sample size was calculated to be 37 or more. However, we ran into a difficulty in assessing the visual acuity during preliminary experiments. Although patients clearly stated that their vision had improved, conventional testing methods like the Randall C or E-chart were unable to detect this improvement. So we studied about visual acuity, and we found that it consists of the following 4 elements, and that only minimal separability can be evaluated using the Randall C test. Therefore, we introduced the CSV 1000 visual acuity test, which can evaluate all 4 of these elements. The advice from ophthalmologists were extremely helpful in making these preparations. So as you see here, the retinal blood flow increases after CEA, and the retinal blood flow increased after surgery only on the operated side. In addition, vision improved after surgery only on the operated side. This was published in the ACT Neurochirurgical. Although we started submission of this study, we kept receiving rejection letters. Facing harsh criticism head-on can be mentally draining and often leaves you feeling more hurt than the word themselves. However, it's important to acknowledge good feedbacks with gratitude and revise the article according to them. Even when faced with unpleasant feedbacks, express gratitude and do your best to address it. It's also necessary to forget some emotional harsh words. It will be good to avoid taking them too seriously and personally. The most important thing is to make use of the advice to your next study. Actually, the comments from the reviewers were very helpful. For example, one reviewer asked us to confirm whether the results showing improved vision with CEA can be generalized regardless of the surgical method. So we decided to use a multi-institutional scheme next time. Another reviewer wondered if similar results can be obtained with CAS. Therefore, we decided to conduct the next study. In the next study, we used OCT angiography to measure the vessel density of the retina. We have recently published this study in neurosurgery. In this study, 39 patients were assigned to CEA and CAS respectively. The decision on which treatment to perform was left to the discretion of each collaborating research institution. This table shows patient demographics. The rate of male patients was significantly higher in the CEA group. I don't know why, but otherwise, there were no differences between the two groups in other factors. Let me tell you that there is no significant difference in the rate of unstable plaque between two groups. These are two representative cases. Figure A to C showed a case being treated by CEA with increased retinal blood flow. Figure D to E, and remarkably improved retinal blood vessels density. Figure H to J demonstrated a case treated by CAS with increased retinal blood flow and moderately improved blood vessel density. The left figure shows the retinal blood flow on the operated side before and after CEA and CAS, respectively. Blood flow increased significantly after both treatments. However, as shown in the right figure, AUL-CSF, an indicator of visual acuity, increased significantly after CEA, but no improvement was observed after CAS. The criteria for using internal shunts in CEA and methods of distal protection in CAS varied among facilities, but these differences did not affect visual outcomes. Finally, we investigated the effects of retinal microembolism. Figure A shows that the detection of DWI high spot on the postoperative brain MRI was correlated to no improvement of visual acuity. Retinal microembolism study was conducted in 39 of 78 patients. Figure C shows that retinal blood vessel density was significantly reduced in patients with DWI high spot on brain MRI. Additionally, as shown in figure D, retinal blood vessel density was significantly lower in patients after CAS than after CEA. In conclusion, following CEA, it was once again demonstrated that ocular blood flow significantly increased and visual acuity significantly improved, regardless of surgical technique. On the other hand, following CAS, ocular blood flow increased, but visual acuity did not improve. A decrease in retinal vascular density due to microemboli following CAS may be hindering visual acuity improvement. Of course, prevention of stroke is of utmost importance. There is a possibility of improving visual acuity on the affected side. Our result may help surgeons dedicated to achieving the best possible patient outcomes. There are topics around you, young colleagues. For example, I guess you young colleagues usually do chronic subdural hematoma surgery, but insufficient hemostasis of the skin and the bone can cause blood to accumulate in the hematoma cavity like this. Our recent analysis has shown that this was done by my young colleague. This study shows that this increases the risk of recurrence. I think this is a very respectable clinical study. This is the basics for clinicians. So this is my last slides. I hope you enjoyed my presentation. Thank you very much. Thank you for your attention.
Well, thank you very much, Professor Soichi, for this nice overview. That title, you have covered it very well. And I think just a few comments I'd like to say first. You have draw attention that mentorship is very important at the early stage of your practice, because sometimes even you have critical clinical thinking, but you don't come to the idea. You need somebody to point something for you that you will start doing it. And of course, we have to apply like in life. You should always rise after a fall. So if it was rejected first time, be perseverance and persistence, try to modify it, accept the critique, as you have done in several papers. One of the papers was 5 times rejected and reviewed. You did not give up, and you continue on that and share. And of course, the most important in clinical research is the passion and the curiosity. This what made Leonardo da Vinci to come with the invention, Einstein to come with the ideas. These ideas came from everyday work or from their lab or from sleep. Sometimes the idea comes during the sleep. You sleep after surgery and okay, I should think about it, study it. So these are where curiosity and passion. And I think in the Japanese culture, I like that book, Ikigai, because this is what makes you leave your bed in the morning to go to work and investigate and take care of patients. And as I said, these ideas comes at work. It can come at a conference. Sometimes you discuss an issue with a colleague and he brings you some ideas that you go back and search for that. And of course, from everyday encounter, being in clinic, in the lab, in the OR, and in anywhere, because this is what it comes for you with the idea. So clinical research has 3 major components. As you mentioned, it should have a purpose. You don't want to publish for the sake of adding a paper on your CV. It has a purpose that it will help others when they confront with a similar situation. And of course, it should have a message. So safety is important in all these clinical research, efficiency, and of course, it should exceed the available. You should not only duplicate confirmed results that has been published 100 times and you add 1 more paper to that. You should feel that it will add and exceed what is available in the literature. So you develop the questions and formula, a testable hypothesis, as you have done in many of these vascular cases, wonderful retinal evaluation of the vision. And of course, you refuse to biostatistics. The other important message you have wrote that the size of the research is not essential. All these papers started with the case report. Sometimes the case report make a difference in the clinical practice rather than a randomized, multicentric, more exceeding 1,000 anterospective, because many of say, oh, this is not an anterospective studies, it's not interesting. How much we can get in anterospective studies on a small portion of a disease entity. You see, Hemangioblastima, you cannot collect a large number in one institution. So, but you have made very clear that the size is not important, but the purpose is very important. And I think you cover it all. The other things, the site of your institution is not very important. You should not say, I'm working in a remote area in a small hospital. This is a secondary. Research is not important. This goes parallel to your clinical practice because this connects the neurons of your own decision together, rather than say, I'm waiting until I move to the big institution. Big institution has thousands of colleagues. You might not have a chance to lead on any of this research immediately. So you start wherever you are at the stage you are. You should not wait, I will do it later, I'll focus on research after 5 years. You will miss the train. So this is an important message you gave. Very good example at the start of your presentation on the issue that's neither the size of the research or the place where you are practicing is the paramount important. Well, thank you very much for sharing this experience. And I think many of the young, they will benefit from this presentation, including myself. not as young, but I have learned a lot from your presentation. Thank you.
Thank you.
Thank you very
Thank you.
much.
Thank you very much, Prof. Imad and Prof. Suchiya, for this very wonderful session. It was indeed very a great learning experience for the young neurosurgeons to hear the story of your research and everyday clinical practice. Thank you very much. We are open to this discussion. Professor Champagne or Dr. Libun Singh, any questions or queries, comments?
Yeah, thanks, Professor Oya, for very fascinating and encouraging way of looking at our work. Probably I would like to get a comment from you because in neurosurgery is still very young subspecialty and we are evolved all the time. But what is more concern for me myself is a lot of times when we found some pathology and the patient was labeled as asymptomatic, I feel that current battery of tests that we have may not enough for us to evaluate. I believe that the patient you have for CAS and even for CEA are not 78 of them have visual problem, but you do able to demonstrate that there's improved in visual acuity because our test is not sensitive enough. We just take a gross complaint by the patient. I feel that we need to develop more tools, especially when we look at ruptured aneurysm. We only take one parameter, small size, and we think the small size is represent everything, but we do have small size aneurysm that ruptured. So there's no parameter for us to study about wall property, for example. So I believe in neurosurgery, there's much more for us to explore, and we need to look for indication for treatment rather than wait for the patient to complain. We also, besides patient symptomatic, we also need to look at the changes that we predict the outcome. What is your opinion and how do we develop in this aspect, Professor? Thank you.
Okay, thank you for your questions. I think that, like I presented, it was not easy for us to detect to find the proper the method of assessment or to prove what patients are saying. So where we need some team and we have some different eyes from different perspectives. So I have many friends like whose background is like ophthalmology or pediatrics or any. So we have to make a team, to have a different views. That's a good way to solve the problem. And I couldn't understand your question regarding the aneurysm. Oh, you are muted.
Yeah, because at this point of time, although we have other factors, we look at familiar, history of hypertension. But again, the most guideline tell us about only looking at the size, for example. And we do have a small size aneurysm ruptured cases. And again, we do not want this to happen to any of our patients where we have diagnosed, but we don't do it because of the guideline. So I thinking that we need to evolve in terms of looking for indication for treatment, have more evolution in terms of investigation that we need to be carry out. For example, some people are looking at the wall aneurysm wall enhancement. For example, that is also one of the good example. Yeah. So I think this need to be evolved in all aspects of neurosurgery. I just got aneurysm as one of the example, and you show that even visual acuity changes did complain in one of the patient, but you did found actually it shows improvement in many patients. Probably they may not be symptomatic. So I think the definition of symptomatic, we need to redefine neurosurgery. What is your opinion, Professor?
Yeah, yes. So we are now looking at the patients with glasses we can use, so that their symptoms or whether it is symptomatic or asymptomatic might be different from different points of view. So if you have encountered some problems in your daily clinical practice, I think you first you have to refer to the. I'm talking to the young neurosurgeon, not you, but you should refer to the existing literature first, and then if you cannot find any solution for it, please start small, a preliminary study for it, and you may be able to find some good way to solve the problem. That's your study. That's my comment.
Thank you, Professor. Thank you.
Thank you. Yes, Prof. Imad?
We have time to add one short comment.
Sure.
Yeah. Well, this is another message you have given, Professor Stoichi. It's very important, the teamwork. Because you see, as a neurosurgeon, everyday work, you are busy in the OR, you are doing a lot of stuff, and you do some empirical studies. But when it comes to specific research design, you need your colleague in the other discipline. Like myself, I don't go into details of retinal flows, for example.
Mm-hmm.
I need somebody who has done the studies and who has dealt with this on regular basis to teach me and give me hint. And that's what you have done. You have done these studies based on a good experience with an ophthalmologist as dealing with this question. So this is very important. The same with the endocrinologist. You have done that case in central myelonesis with the low sodium and how you have to replace it. You went back to the literature as a young trainees, and then you are consulting your endocrinologist for the management. So same with the images about the ophthalmology and the ophthalmic artery. You went to your colleague, junior colleague, that he has studied all the angio and the ophthalmic artery, and you came with the idea, you formulate the idea and the hypothesis of the value where to clip and how to clip and to avoid stroke. So I think it's important, the teamwork you have mentioned about. Thank you.
Thank you. Prof. Champagne, any comments?
Very interesting presentation. Thank you very much, Professor Oya. I think it resonated with me on a lot of levels, especially when you state, I think we cannot undermine the importance of curiosity in research. And there's the small steps with case reports, I think, is really important, not only for the sake of publication, but I think that looking at our patients, our data, being curious about our cases, make us better surgeons, because we take a subjective look on our patient, on how we treated patient, and it's I think the best surgeons I know are those that think like that and that always look at their patient, their series, and strive to do better. So doing research is not only good for publication or to help gain knowledge, but also to become better surgeons, because we take a different outlook on our cases and what we do, and that's really what that resonated a lot with me on that aspect. Thank you very much.
Thank you very much. I think it's all connected,
Yes, I think it is. So thank you very much. It was very useful for everyone, I think, from youngsters to the elders as well. So thank you very much, Prof. Suichi, for this wonderful lecture, and thanks, Prof. Imad Kannan, for sharing and sharing your wisdom with us. Thank you very much. So we'll move on to the second session, and I would like to invite Prof. Champagne for chairing this session, and we will say a short introduction and invite Prof. Nidan for his lecture. Champagne.
Thank you very much. So it's my pleasure again to be invited to chair this session. Thank you very much for this kind invitation. So without further ado, I would like to welcome Professor Nidan Qiao, who is going to talk to us about intelligent diagnosis and treatment in cellular region tumors, a topic I'm quite interested in, and I can't wait to hear more about.
I'm Nidan Qiao from Shanghai, China. I'm going to talk about intelligent diagnosis and treatment in pituitary disease. So we all know that cellular region is located at the center of the brain. Pituitary adenoma, craniopharyngioma, chordoma are very common diseases located in this region. Cellular region is also called a neuroendocrine center. So patients may develop neurological symptoms like visual impairment, hydrocephalus, headache, oculomotor paralysis in this patient. Also, this patient may have a endocrine disorders due to the compression of pituitary gland. So these symptoms may include hypopituitarism, Cushing's disease, acromegaly, infantile and impotence. So we all know that machine learning and artificial intelligence is very hot in daily research life in our in current research. So in this research, we have 3 steps to do these researches. For example, constructing a machine learning model or an AI model, and validate that model in a external data set, and then we have to explain these models in a clinical setting to facilitate the application of these models in our daily clinical application. So today I will talk about how we use machine learning and artificial intelligence in the preoperative diagnosis, intraoperative guiding, post-operative prognosis in patients with pituitary disease. So first I will talk about preoperative diagnosis. We all know that silent ACTH tumor is a special type of pituitary adenoma. This patient may have no clinical presentation of Cushing's syndrome. They are female predominant. The pathology shows positive for TPIT or ACTH. These tumors may have high risk of tumor recurrence compared to other types of tumors. These tumors may also have a huge tumors or huge invasiveness to the sphenoid sinus compared to other tumor types. So how can we differentiate these tumors with other pituitary adenomas? Is very important because these could guide our surgery. So we developed a radiomic workflow to diagnose these tumors before surgery. So first we collected a multimodal MRI for example, T1, T2, and T1 contrast. Then we segment these tumor areas manually, and then we can do the feature extraction to the tumor area that we segmented. These radiomic features can be combined together, and we can add some thematic features like clinical report, MRI reports, or laboratory test to these radiomic features together, and so that we can use these combined features together to predict if the patient had a silent ACTH tumor or other tumors. So looking at this figure, we can see that only using radiomic features we can differentiate these tumors correctly, like the tumors with silent SCA were differentiated in the right lower part of this figure in the blue area, in the blue dots. And by combining all the features together, using the radiomic features and the thematic features together, we can develop a very good classifier. The AUC of the ROC curve is more than 0.9, which suggests a very high accuracy differentiating 2 types of pituitary adenomas. And when we are looking at the feature importance, we can see that radiomic prediction, using the radiomic features, is very important for the prediction. And other types of features like gender and age, for example, a female gender, a age between 30 to 50 years old is also very important to predict this kind of tumors. So that if we predict a patient is a silent ACTH type pituitary, we can have a more aggressive surgical approach, or we can have a radiomic therapy after a subtotal resection of the tumor to decrease the probability of future recurrence of these tumors. Talking about segmentations, the study we are talking about is that we are using a manual segmentation. So our surgeons or our radiologists must segment these areas of tumors manually. So if we are having a lot of data, this is very tedious work. So we developed a model that can automatically segment these tumors. So using this tumor, we can do two tasks. The first task is automatically segment these tumors. The second task that this model is doing is that the model can tell us if the tumor have a cavernous sinus invasion or not. So that this is the result of this model. The last column is the ground truth. So this is the result that we are segmented manually in the last column. The second last column is the result of our model. The model can segment the tumors automatically, just like we segmented the tumor manually. And also the model can tell us very precisely that if the tumor have a cavernous sinus invasion or not. And in the right side of the slide, we can see that the red area here is that this is an invasion tumor. This is an invasion tumor. The model tells us this part, the yellow part, or the red part is, the model tells us this is very important to the model, that the model pay a lot of attention to this area that determine the tumor is invasive. In this plot, also the model tell us this, that this is very important, that the model pay us attention that the tumor is invasive. So using this plot, we can trust the model that this area is just like us in neurosurgeons. We also pay attention to these areas that we can determine if the patient had a cavernous sinus invasion or not. So we can trust the model. Okay. So the second part I want to introduce is the intraoperative guiding. In pituitary tumors, we pay a lot of attention to that the tumor, if the tumor is soft or tenacious. If the tumor is very soft, the surgery is very the surgery may be quite easy. Okay, so if the tumor is very tenacious, then the surgery is difficult, and patient may have subtotal resection, and the complications may be high. So DWI image is very important to determine if the patient is soft or tenacious before surgery. In our daily life, we can scan the tumors for quite a lot of image models like T2, T1, T1 contrast, DWI. So scanning for these image models, we can have more than 10 minutes or 15 minutes for every patient. So for like a centers like us, we have a lot of patients daily. So this scanning is very time consuming. So we want to find a method that can decrease these timings for scanning for a single patient. So we developed this method. This is a CycleGAN method. So we can turn original T2 scans like using these models into a synthetic DWI images. So this is our result. So we can see that this is an example of a soft tumor in the left side of our slide. So this is an original T1, T2 scan, and we can converge these T2 scans into a synthetic DWI scans in the third columns. So these synthetic DWI scans is quite similar to that we scan really. So that our method is quite useful in our daily clinical settings, that we can use this synthetic AI method to replace our real scans in our daily life. And the synthetic scans can also help us to determine if the tumor is soft or tenacious, so that we can decide what kind of surgical approach we use in the surgery. And also in the right column is a example of a fibrous tumor. And also we can see that the ground truth in the second column is quite similar to that in the third life. This is our synthetic DWI scans. So that using this synthetic method, we can reduce the real MRI scannings of 10 minutes to less than 5 minutes in our clinical settings. Talking about clinical approach to resected tumors, we developed a transnasal plus a transcranial surgery for complex giant pituitary tumors, especially for a very tenacious consistency in our clinical settings. We have performed a transnasal and transcranial approach for more than 200 cases in our clinical settings since 2022. And we have performed a comparative effective analysis in this approach. In this figure, that we can see in the surgery theater, we have two groups of surgery. A group of surgery performed the transcranial approach, and the other group of surgery performed the transnasal approach. And for these kind of complex giant tumors, we can perform a total resection for these tumors. And for comparative effective analysis for these giant tumors, we all know that in this real data analysis, patient may have different of confounders comparing to different approach. So in our analysis, we use the machine learning driven confounding adjustment. We developed a propensity score for each patient using a machine learning approach. And we matched the patient with a similar propensity scores together. And in this cohort, we can assume that there is no confounding factors in this matched cohorts. And we can see in the right figure, using the dotted line, we are presenting that the patient using the variables differences before the matching. And we can see there's a lot of differences in every variables. And after the matching, we are presenting using the solid lines. And we can see from this figure that after matching, all the variables have only a little bit differences, saying that in these matched cohorts, we can assume there is no confounding factors. And using this technique, we compared more than 1,600 cases of giant and complex pituitary adenomas using different approaches. For example, we are comparing 62 cases of combined approaches using a simultaneously transcranial approach plus transsphenoid approach, and to that more than 500 cases with single approaches. And in this study, we included more than 10 centers in all Chinese territory, and we confirmed that using the combined approach, we can increase the total resection rate from 40% to more than 50% using the combined approach. And we also testified that the combined approach can also decrease the incidence of severe adverse events from more than 10% to 3%. And we can see that from this figure, the combined approach is very effective to resect patients with giant and complex pituitary adenomas. And this is a case using a combined approach to resect a patient with acromegaly. The patient has a very huge tumor before surgery. The growth hormone level and the IGF-1 level is very high. And the IGF-1 level decreased to less than 1. And after the operation, the MRI showed a total resection of the tumor, indicating an endocrine remission. And the last part I want to introduce is the post-operative prognosis of this patient. The first one is that we all know that pituitary tumors in pituitary surgeries, we can have a very high risk of VT events after these surgeries. The VT events may include a PE, pulmonary embolism in the pulmonary artery, or we can have a deep vein thromboembolism in the bilateral lower limbs. And in this figure, we can see that the high risk of these events may occur in the 10 days after pituitary surgeries. And we developed a machine learning model to predict if the patient could have a pituitary surgery, could have a VT event after pituitary surgery. And in our model that we can see from this AUC curve, our model is better than the previous models like Caprini scores and Padua scores. And in the right side of this slide, we can see we can also have some risk factors for VT events like high D2 levels, a high volume CSF leakage during the surgery, craniopharyngioma, and a old age, which are all risk factors for these patients to develop a VT events. And we also developed a Huashan VTE prediction application in the online application. Doctors can use these applications to input some variables and calculate the VTE probability after surgery immediately to guide their post-operative management. And we all know that this patient may have a recurrence after pituitary surgery. So we developed a pathology-based prognosis scores after surgery to guide a future therapies for this patient. So we all know that H&E slides are very important to determine a prognosis of these patients. So we scanned we digitalized all these patients using the digitalized slide, and we can segment all these cells, and we can extract the cell area, the nucleus area, the nucleus perimetry, the cell perimetry, and we can combine these features together, and we can have a morphology clusterings using all these features. Also, we all know that we have a lot of immunostainings for this patient, and we can have a immunostaining scores, and we can develop immunostaining clusterings using these immunostaining slides. And for the first, we can have a morphology clusterings based on the H&E slides, and we can develop we can subgroup these patients into 2 clusters. And we can see that these 2 clusters have different probabilities of recurrence. And we can have samples from cluster 1, and these cells have a uniformly cells and nucleus. And another sample from the cluster 2, we can see cells have a large and a small nucleus, and a patient we also have a large and a small cells, and these are different cells, suggest a high probability of recurrence. And also we can have 2 types of recurrent, 2 types of immunostaining clusters, and these 2 clusters have different probability of recurrence. And taken together, we can combine the morphology clusters and the immunoclusters together and to develop a total risk profiles for this patient. We can develop patient into 3 risk profiles: the low risk, the medium risk, and then the high risk. And these 3 risk profiles have different recurrence probabilities. So this is a summary of the features of these 3 clusters. So for patients with high risk, these patients have a small and high cells, small and high nucleus, and different. Okay, so I won't have a conclusion and outlook of our research on the artificial intelligence research in pituitary disease. So we have published a lot of papers using the machine learning approach and artificial intelligence approach in patients with pituitary adenomas, in craniopharyngiomas, and all these papers are about the how can we have a further management for these patients. So we have do this research for 10 years, including diagnosis, surgery, radiotherapy, medication. So first in 2015, we are doing a simple machine learning. We use limited variables. We are predicting simple tasks. And in 2020, we used a deep learning approach. We have extended our variables to multi-variables, and we can predict multi-tasks. And in the last year, we are doing a foundation model. We all know that this is very hot in these years. We are using the large language models. We are using the foundation models to do a lot of research to replace human beings, to diagnosis, to treatment, to treatment recommendations to these disease. We can include in multi-omics data like radiomics data, pathologic data, and also the genomics and the O-link data. And we can do this full cycle strategies recommendation for this patient. And we are doing now is that we want to develop a pituitary foundation models. So these models may include diagnosis, treatment, and follow-ups. So for every patient included, we can have a diagnosis to see differential diagnosis, subtyping, the endocrine diagnosis, ophthalmic diagnosis. We can have some types of treatment recommendations. What is the optimal treatment? First medication or first surgery? What is the surgical difficulty of this patient? How high is the surgical risk? What types of integrative therapies that the patient may have after surgery? And after treatment, what is the recurrence of this patient? How often we have to follow up this patient? What is the endocrine reconstruction of this patient? What is the quality of life for this patient? And all this together, we can combine it together to do this intelligence-driven clinical management strategies for this patient. And we are do these things nowadays. So this is my colleagues. We are collaborating with endocrinologists, ophthalmologists, the AI scientists, pathologists, and professors from Mass General Hospitals. So we are now doing the Pituitary Foundation models. If you are interested, you can contact me using this email address. We are collecting clinical notes, imaging DICOM, pathology scans, and patient's prognosis for pituitary adenomas and stellar region disease. Thank you. Thank you for your watching.
Thank you very much, Professor Qiao. It was very, very interesting. It's very enlightening to see how you guys integrate AI in the and machine learning into the management of pituitary tumor, mainly adenomas or pitnet now, as we should call them. I have a couple of questions regarding your talk, but first, a fantastic presentation, very nice topic. I had when you were talking about the diagnosis using the radiomic features, and especially the invasiveness of cavernous sinus. I was curious about what was your endpoint about the cavernous sinus invasion. So you said that the algorithm or the AI could help you define if there was cavernous sinus invasion, but as you know, sometimes we see cavernous sinus. There's a difference between radiologic cavernous sinus invasion and clinical cavernous sinus invasion. When we end up operating these adenomas, we end up seeing that the medial wall of cavernous sinus has been pushed back, and there's no real invasion of cavernous sinus, even though if the superior compartment, or less frequently the inferior compartment of cavernous sinus, seemed to be full of tumor. In the end, it was just the wall that was pushed back. And I was curious to know in your presentation, the outcome of cavernous sinus invasion, was it radiological or was it a surgical assessment?
Okay, so this is a very good question. This is about how we define the ground truth of our AI research. So in practice, we are using the clinical aspect of the cavernous sinus invasion. We documented the determination of our surgery during the surgery, if the patient have a cavernous sinus invasion or not, in this study. So we also admitted that this is also a limitation. So even if we are we decide there's no cavernous sinus invasion by our doctors, we cannot say this is the fully 100%, because we can also see there's cavernous sinus by pathology if we cannot see using our eyes, right? So this is also one of the limitations of this study. Okay.
Thank you very much. I will bounce on that subject. At some point, are you interested in integrating AI to analyze surgical videos of really video data that's done during the surgery? I've seen, I think in one study it's been done like just to identify structure. AI is there like to say like this is pituitary, this is
yeah, this is very true. That I also saw some studies using the AI techniques to segment the surgical procedures.
I was also very interested when you talked about the you used T2 images to get DWI sequences that are kind of virtual. On that aspect about predicting the consistency of the adenoma, do you think it might also be a confounding factor? Because we know that T2 weighted images tend to predict the consistency of tumors, since we know that it's sensitive to the content of water, and that higher T2 tumors especially has been studied a lot in meningiomas. We know that meningioma, and I think we've all seen it, meningioma that are have a high T2 intensity tend to be softer than those that are less T2 intense. Do you think that using T2 to build this virtual DWI sequence to predict consistency might be biased by this aspect?
Yeah, we compared the prediction accuracy using the original T2 and the virtual DWI in predicting the consistency of the tumor, and we found that the virtual conversion can increase the accuracy, and we also compared the real DWI and the virtual DWI, and we found the accuracy is similar. I think that your question is very important, so that we did not think about that. We can also have a consideration of your recommendation in that aspect. Thank you.
My pleasure. It's very interesting to be able to save time on imaging too, because it's a big problem for us too. We do some research with experimental MRI, and it's always imaging time is always an issue. And on that aspect also, because I'm curious about your resolution, because we know that DWI sequences tend to have really low resolution and really big voxels. Can you get a higher resolution using
of course.
using the T2 virtual sequence, or do you get a similar resolution than in DWI?
I think this is a similar resolution. So we are. This is a bulk. I think this is a bulk prediction. So we can have a different, heterogeneous consistency in the pituitary adenoma. We can have different consistency in different part of the pituitary adenoma, right?
Absolutely.
So we did not try that part yet. We can try that part. We can have a heterogeneous part consistency in pituitary adenoma. So we can have a different measurement.
Great, thank you.
We can do it later.
One last question was about the this combined surgery you do for giant cases. I was quite impressed to see the in your surgical setup, you're actually doing both the open and endoscopic approach at the same time with like 2 surgical teams. Is that correct?
Yes, that's correct.
And at some point, do any other team feel that the other one is in its way? Because it seems to be a lot of people around a single head. But I tried to figure doing this in my center with 2. Maybe it's our ego in North America that's so big that we just want to take as much place as we can. But it's I felt that having especially in endonasal, since we operate with 2 surgeons, with ENT and neurosurgery, plus doing a craniotomy at the same time, I felt that in my center, I don't think it would be possible to do both at the same time. How did you manage to do with this? And even while doing the craniotomy, I guess the head was going to vibrate. And can the person doing the endoscopic part operate at the same time?
Yeah, I think this is a very important question. This is quite true if you are doing a combined surgery. If the craniotomy, so if we are doing the craniotomy in the right side, it's very narrow. It's very and we have a very narrow space for both teams. However, if you are doing a craniotomy in the left side, this is a very I think this is you have a spaces for both teams, right?
Yes, I got
so
that.
If we are doing the right side of craniotomy, we are doing the right side craniotomy, we can have one group of doctors perform the surgery first, and then the other group of the surgery perform the surgery. And then if we have resected tumors, we can have the other group of the tumor do the surgery. So this is also, we can do the surgery in the same day, and different group of surgery can perform the surgery step by step. And we
Yeah.
can
So taking turns during the day.
turns by turns, and you can save spaces.
That's great. Thank you very
Especially
much.
you are perform the surgery in the say in the left side carrier approach.
Great. Thank you very much. That was a great talk. It's so it does it for my question. I'll let the others, if others people have comments or question. It's good for me.
Thank you. We'll open this
Thank
for
you. Thank you,
discussions. Any
Professor Champagne.
questions from Prof. Oya or Dr. Libun Singh?
I think that my question is related to the last question from Dr. Champagne. So if you do the combined surgery, you sometimes use the small craniotomy and the endoscopic surgery. It may create more spaces for surgeons doing the craniotomy part, or you always use the microscope.
Yeah, for our teams, you for the cranial part, for the craniotomy part, we use exoscope. We also
Exoscope.
use microscope. Yeah, we also use microscope.
How do you decide which one to use?
This is up to the experience of different doctors.
Oh, okay. The preference.
Okay.
Maybe.
Yeah.
All right. Thanks.
Yeah, thanks, Doctor, for a nice presentation. I have two simple questions. Is your AI model be able to perform relearn and unlearn when you feed with the new information? Because even as a human being, it's quite difficult for us to relearn and unlearn something that we learned before. So whether your AI model can do it when you have a new technology, a new, as for example, HPE or genomic study data, to tell them, no, this is wrong, this is right. My second question, do you foresee that in the future, with just AI model or machine learning of neuroimaging, one day it will replace the stereotaxy biopsy, which are invasive in terms of diagnostic purposes? Thank you.
So the first question is very important, that relearning is very important if we have new knowledges of the patient. In the previous decades, we cannot use these relearning techniques if we have new knowledge. However, when we are developing these large language models nowadays, these foundation models, these models can be updated by our knowledge of the doctors. So we can update the models daily in our daily life using the correct language by generated by our doctors. So this is very important in refreshing and updating the foundation models. And for the second question, if we can have a replacement of the doctor's biopsy using the AI models, I don't think so. The AI models can facilitate more accuracy diagnosis. However, the pathology or the genomic diagnosis is very, I think this is also very important. I don't know. I don't know. This is for maybe for future answers. I have no answers for this question. Sorry.
Thank you for your nice presentation. Thank you.
So, well, thank you very much. We come to the end of this webinar. I am extremely grateful to Prof. Nidan Qiao for sparing his precious time with us. I know there were some hiccups, but thank you very much, and thanks Professor Champagne for chairing this session. So I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Soichi Oya and Dr. Nidan Qiao, as well as the chairs, Prof. Imad Kanan and Prof. Pierre-Olivier Champagne, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And I would like to mention to our viewers that this has been broadcasted on YouTube, WeChat and Zoom. And as of now, we have around 400 people who have logged in through all the 3 different channels. So thank you very much, and also special thanks to my co-host Dr. Liu Boon Seng for joining me today. So until we all meet tomorrow online, it is bye bye from all of us. Thank you very much for joining.